Okay, I think we're ready to get started again. Kara, do you need to take a roll call?
Yes, I do. Welcome back, everyone. So, members, please state your name when I call it. Bill Herman, Chair.
Present.
Pat Schumacher.
Present.
Howard Tracer.
Present.
Barry Marks.
Present.
Naomi Fukudawa.
Present.
Donald Schell.
Present.
William Chung.
Present.
Aaron Lapata. Aaron Lapata. Aaron, you could be muted. We'll come back. Jana Town.
Present.
Barbara Linder. Barbara Linder. We'll come back. Captain Samuel Wu.
Present.
Paul Conlon.
Present.
Ayatandem Dakun. Carol Greenlee.
Present.
David Strobat.
Present.
Dean Schillinger.
Present.
Ellen Leake.
Present.
Jasmine Alvo.
Present.
John Boltry.
Present.
Meredith Hawking.
Present.
Shannon Itzig.
Present. Present.
Sherry Boland. Sherry Boland. Bill Cook.
Present.
All right, we'll try again. Aaron Lapata. Barbara Linder. And Sherry Boland. Dr. Herman, there is a quorum.
Great. Thank you. We'll turn it over to Doctors Paul Conlon and Carol Greenlee for the Treatment and Complications Subcommittee update. And I know we're starting late. You'll have an hour for your presentation.
Thank you. Next slide. These are the members of our subcommittee. You've seen this before. Next slide. So today we're going to go over all of our current draft recommendations. This is the order that we will go in. Next slide. Just to remind everyone that we recognize there's a huge universe of things we could tackle under treatment and complications, but we recognize that the biggest gap is between existing resources and existing resources as they become available, newly available, and getting those resources to the benefit of the people with diabetes. We want to reduce that gap to optimize the treatment and outcomes of people living with diabetes. We wanted to focus on what was going to have the biggest impact for the most people and that were applicable to federal programs or policies. And we also wanted to do, as Dr. Conlon already mentioned, have sort of an evergreen approach because new teaching techniques, new knowledge, new diabetes technologies, new ways of reaching people and providing care will be coming down the pipeline, and we didn't want to just put a Band-Aid on now. We wanted some sort of mechanism for adapting and adopting these new mechanisms and technologies as they came along. Hopefully you'll see that in our draft recommendations. Next slide. One of the things that stands out about diabetes and has already been mentioned many times is that diabetes is more common and the diabetes outcomes are worse in currently underserved communities and populations, including rural populations and communities of color, lower income, and lower education. As we were doing our evaluation of federal agency programs and policies, it became apparent that some of these were having the unintended effect of worsening rather than reducing disparities. We put together a draft recommendation around health equity, and much to our delight, on January 20th, 2021, President Biden enacted an executive order on advancing racial equity and support for underserved communities through the federal government. This executive order asked the federal agencies to identify a policy or a program and evaluate it for how it impacts disparities and to collect data so that they can monitor the impact. We decided to continue with our health equity draft recommendation to be more encompassing around diabetes. Next slide. And not just, there's no guarantee that diabetes will rise to the surface within this executive order. We have changed the recommendation to be more inclusive all the way and more clearly inclusive. Before we just said impact on diabetes, we now specify that we recommend that health equity should be a component of all policies and programs that impact diabetes prevention, prediabetes, and diabetes. To all federal agencies involved in healthcare for people with diabetes or at risk for diabetes, we recommend, and more specifically here we have included for all new, all revised, and select existing policies and programs that impact diabetes prevention, prediabetes, and diabetes, the relevant federal agencies will prospectively consider and retrospectively evaluate the impact on health disparities, and federal agencies will ensure collection of appropriate and relevant data and will use such data to assess the impact, and here we emphasize modify the policies and or programs to reduce health disparities. So the changes were to be more inclusive, diabetes prevention, prediabetes, and diabetes, and to specify modify. Any comments on this draft recommendation? And I'll hand it off to Paul Conlon.
Great, thank you, Carol. I appreciate all the work that you've done with us on this subcommittee. I'm going to merely moderate the remaining portion of the presentation that's going to have discussions by Jasmine Gonzalvo, Sherry Bowen, William Chung, and Dr. Greenlee with Ellen Leak. So I'm going to, if we could advance to the next slide, I'm going to pass this to Jasmine Gonzalvo, who's led our subgroup work related to diabetes self-management, education, and support training. Jasmine.
Can you hear me, Paul? Maybe I can double check with you that I'm coming through clearly.
We can hear you. It's soft. Please proceed and stay as close to the microphone as possible.
So I'm not really sure what the issue is, but hopefully we can get through. Essentially, we are continuing, we haven't made too many modifications to these recommendations, really just looking at the underutilization of DSMES and continuing to essentially recommend that DHHS and CMS expand access and reduce barriers to delivery of DSMT by reducing the administrative burden associated with DSMES, creating a task force with the authority to update the Medicare quality standards that govern DSMT, and establishing a process for ongoing timely review, as well as making the telehealth waiver for DSMES or DSMT permanent. Those are largely unchanged, and really in looking at addressing the public commentary that we have had relevant to DSMES, we hope to be accomplishing a lot of what has been mentioned in the public commentary through this overarching recommendation establishing the task force to review some of the standards and have more of a broad scoping review and update and revision of those quality standards to address some of the comments that have been made in the public commentary.
So why don't we pause and seek comments and feedback about this recommendation?
Yeah, Jasmine, this is Dean Schillinger. Does the word task force have any particular meaning within federal agencies or DHHS, or is there a particular reason that term was used?
I might have to default to Carol and Paul on task force that has
your voice
Sorry,
is
we
cutting in.
can't hear you.
Yeah, Dean, this is Paul. I believe that term is not well defined, but it was, as you could see by the rest of that bullet, it was designed to have a group brought together who really had the authority to make updates to the quality standards. We're happy to modify it if there's a better term that would be.
No, I think it's fine if it's broad. I just didn't know if there was a particular federal definition for what constitutes a task force.
Yeah, we'll work with our federal partners and the DFO to make sure that the language appropriately captures what we're trying to convey.
And I guess as well the question would be whether this task force might be combined with some of the other oversight or advisory agencies that have been recommended by the other subcommittees.
Okay, Jasmine, could you proceed?
Yes, I understand that some people are having trouble hearing me, but I'm not sure how to remedy the problem. My microphone volume is all the way up on my computer.
Why don't we go to the next slide?
And there's a distinction here that we have made a substantial amount of changes to since the public has last seen this recommendation in particular. The distinction here is with this recommendation is this: we're not referring to accredited and recognized DSMES programming here, but rather peer-led diabetes education or community-based diabetes education. And the peer-led and community-based education programs do oftentimes address a lot of the barriers that may exist to accessing DSMES. Our recommendation here to HHS and CMS are to develop reimbursement mechanisms for community-based diabetes education programs when evidence shows that they improve diabetes outcomes as a complement to existing accredited or recognized DSMES programs. And opening it up for comments now.
Jasmine, this is Sherry. I really like the way this is reworded, although, and this is minor, but we might want to switch when evidence to where evidence so that it doesn't make it sound like there is no evidence for any of them. It's sort of a small point. So you can think
No,
of
I see what you're saying. Mary. That makes sense.
Okay, why don't we move ahead?
And lastly, this recommendation is largely unchanged fundamentally as well. There are additional recognized and unrecognized barriers. Referral to and receipt of DSME defined and understood and addressed. Our recommendation for the NIH is to prioritize funding for research to explore factors that affect referrals to and patient uptake of DSMES, such as patient and systemic level barriers, quality measures, and patient-reported outcomes. And again, not too much changed with this recommendation last presented. So, comment here?
So the rest of the audience may not have heard Jasmine fully. This recommendation is a carry forward from previous presentations, and I'm not sure that it actually has any modifications from what's been presented before.
Just a question of clarification, Paul and Jasmine. What does patient uptake mean? Yeah, I'm going to go to the DSME class or the DSME visit, or does it also mean and the recommendations that were made I can actually accomplish at home or in my community? I'm just wondering if there is an opportunity for complementarity with our subcommittee.
Dean, I think it's a good point, and we should probably explore that with your subcommittee, as I feel like we actually have recommendations that complement your recommendations as well.
Okay,
Thank you.
I think, Dean, if you could probably hear, Jasmine was expressing willingness to cooperate with you and your subcommittee and combining this maybe with some of your recommendations.
And I'll just jump in. This is Carol. We do know that a number of patients think they don't need the diabetes education, so that's part of what the uptake means, but I agree that we should pursue it on multiple levels.
Right. It's the question of, are they accepting the service of the SME as a service, as well as are they able to then take the lessons learned and apply them, uptake them at home. And I think they are separate but complementary concepts.
I agree. I think that's an excellent point.
Yeah. We appreciate the ability to clarify that. Okay, why don't we proceed to the next slide, and with this I'll introduce Dr. William Chung, who has led the subgroup focused on diabetes technology. Bill?
Yep. Thanks, Paul. This first slide just provides some background into the reasons for our recommendations. I just want to highlight that this hasn't really changed much since we presented these recommendations previously, and the recommendations that will follow on subsequent slides are still generally aligned with what we provided previously. So just to summarize this rather than read through all of it, I think what we're trying to highlight here is that there are benefits and advantages to the existing and newer diabetes technologies that are available. Where we're seeing a problem, as Carol highlighted at the beginning, is that getting access and improving utilization of these devices is an area where there's a gap. And what we're trying to accomplish here is that to provide recommendations in a way that addresses those barriers and those burdens that cause the gap. So one of the things that we've heard in various stakeholder comments and in speaking with different groups, that there's an administrative burden that is a problem. There's also some inconsistencies in the requirements and the coverage for those requirements for the materials to achieve those and demonstrate the requirements, and that there's a lag between what new data comes out in terms of supporting evidence for who may benefit from using these technologies and updating the recommendations. So we can move to the next slide. And so the focus of our recommendations here is really to try to make recommendations that will improve access to the proven effective diabetes technologies and to keep pace with the new and evolving evidence. And so, you know, in writing these recommendations, we kind of were aiming at this, and we did review different public comments on the draft recommendations, and noted that while there were people who focused on very specific examples or specific issues, we think that the recommendations as written are broadly encompassing and can highlight ways for those specific issues to be raised in sort of in the report rather than in the recommendations. So we might include some vignettes or other details around specific issues that people are facing. So I'll just read through the recommendations here. So, you know, the first recommendation is to continue to allow for virtual visits for meeting the requirements for continued use of diabetes technologies, minimize disruption of care, and reduce unnecessary burdens for patients and providers. The second recommendation is that we recommend that the current eligibility requirements to be updated now for various diabetes technologies, and then also establish a process for regular reevaluation of the eligibility requirements, such as at least every 3 years, with the goal of this reevaluation leading to national coverage determination for the different diabetes technologies. In doing this reevaluation, it should include review of coverage for testing supplies and other materials needed to determine eligibility, to ensure that patients are able to demonstrate that they meet requirements without unnecessary barriers or out-of-pocket costs. And we also think that this should include evaluating not just data on glycemic benefits, but also non-glycemic benefits of access to these technologies. Next slide. And our last recommendation in the diabetes technology space is related to establishing a process to make sure that there's clear and consistent application of the eligibility and reimbursement requirements across all parties involved. And while I have here listed both Medicare administrative contractors and auditors, our understanding from the patient groups and other people who commented on the inconsistencies here is that the auditors' requirements may sometimes be above and beyond what Medicare actually requires. And so I think that's all the recommendations in diabetes technology, and I'll stop here for any questions.
Thank you, Bill. Why don't we go back to the prior slide, because that has the bulk of the recommendations from your subgroup, and then we can advance if there's no comments here or when comments are done. I will add that these recommendations were uniformly lauded by the public comments and stakeholders that wrote letters in feedback to the draft recommendation. So it appears that this resonated with people from many perspectives. We welcome comments to edit or clarify.
This is Dean again. I just had one question. And I'm sorry if this belies my ignorance, but is the current reimbursement for virtual visits, is it a blanket allowance? And are we recommending that virtual visits can be used for any and all diabetes-related encounters? I'm sorry that I don't know the details about the current waivers and exceptions that have been made for COVID.
This is Carol. I'm going to jump in because we have our televisit recommendation later. This is typically to continue to receive insulin pump supplies or continuous glucose monitoring supplies, test strips, etc., but mainly the pump supplies and the CGM supplies, patients with diabetes, people with diabetes are required to have an in-office visit every 3 months to get their pump supplies, Medicare patients, and every 6 months to get their CGM supplies. During the public health emergency, CMS allowed those eligibility visits to be virtual. And that was a huge benefit to people with diabetes. So here we're only talking about the visits that are required to continue to get your device supplies.
So maybe I could
versus under legislation.
Yeah, maybe I could suggest to make this perhaps even a more acceptable recommendation for our audience that to continue, or how would I put it, to enable the meeting federal requirements regarding meeting the utilization requirements to get technology and supplies refilled or filled, that virtual visits would be included as an eligible visit type, something like that, to just flip it around. But to frame it around, like you said, the continued use of diabetes technologies. I think it wasn't understandable, at least not to me, that way.
Okay. We'll work on that. Thank you.
There is one additional recommendation on the next slide, so why don't we go to that so people have a chance to at least review that and offer any comments if they wish. If there are no further comments, then why don't we move on? Thank you, Bill. The next section is going to be discussed by Dr. Sherry Boland, who led our group focused on team-based care. Sherry, please.
Thanks, Paul. So this is just a summary, a little bit of our background, that team-based care addresses barriers to individualize and optimize diabetes care and the complexity of diabetes management, and that we were particularly focused around addressing issues around behavioral health, multimorbidity and polypharmacy, effective communication between care members, and unmet social factors, as some of the things that team-based care helps to address in diabetes patients. So some of the key barriers when we were talking with stakeholders and also from the literature that we found for implementing team-based care were around these three areas: healthcare workforce shortages, a lack of reimbursement for team-based care. In particular, we were focused around community health workers, pharmacists, and behavioral health providers, since those were areas that were not well reimbursed and were critical to some of the team-based care issues for diabetes patients. And then technical assistance around implementation, support, and strategies to implement this in practice. So our recommendations are really focused around those key barriers. Next slide. And I'm going to skip this. I put it in here in case folks want to be able to look back to some of our background, but I know we're time constrained, so I'm going to skip this. We've gone over it before. It's not new. Just to go through the recommendations. And again, these recommendations are pretty similar. The first one is pretty much the same, and the second one has two sub-bullets. So we took two existing recommendations, we've tweaked those a little bit, and we put it under one broader recommendation. So these sub-bullets are going to be within the recommendation, just to try and minimize how many recommendations we had. So the first one was around the fact that, just as a reminder, that there was a lot of funding going to different training programs, but those primarily, most of the funding was going through the GME payments, and not really meeting the needs of healthcare workforce shortages to meet team-based care needs. And so the first bullet is really around establishing a mechanism at DHHS to routinely assess and identify all healthcare workforce needs, not just subgroups of populations or subgroups of healthcare professionals, and ensure that training program funding across agencies is directed to meet those needs. So that's really the first bullet or recommendation. The second one is to ensure, it's more specific to HRSA, which gets less funding, but is an important agency, to ensure that HRSA training programs meet unmet team-based healthcare workforce needs. And to do this, we recommend the following. One is to evaluate and address regulatory or statutory limitations on HRSA training programs that affect the agency's flexibility to meet the needs of team-based care and new care models. And that was felt to be one of the challenges within HRSA around meeting team-based care needs. And the second bullet was around HRSA has some really exemplary programs, but are underfunded, so increased funding for exemplary HRSA programs which support training healthcare professionals in team-based care, especially within medical shortage areas, such as the HRSA National Health Services Corps, to meet unmet workforce needs. So those are the current two recommendations. I think those are all the healthcare workforce ones, so I don't know if I should stop for a minute.
Yes, why don't we stop and leave this slide up for comment and feedback.
Hi, Sherry, it's Bill Cook. Do you think that substance abuse training in your preamble is sort of inferred when you talk about mental health, or should it be sort of called out individually because they are an important part of the team?
Yeah, that is an important area, and maybe what we can do when we're writing it is in the text we can think a little bit about how to make sure that's incorporated into that so it's clear.
Thank you.
This is Carol. We did intend that when we say behavioral and mental health. Yeah.
Okay, why don't we proceed?
Great, and I will, so our second area was around reimbursement for team-based care, and in particular, again, focusing on areas that have had challenges with reimbursement to be effective, as we've already stated earlier. Next slide. And I'm not sure I'm going to go into all of this except to say that as a reminder, when we get into some of the community health worker specific recommendations, just a reminder that CMS does allow coverage of CHWs who provide addressing social determinants of health, but lack some clarity, and so states don't always know that it's covered. So our recommendations are focused around, for Medicaid, are focused around clarity of language, and we'll get into that recommendation on the next slide. So we've condensed these into two recommendations, or the first, I shouldn't say that, we have more slides, but the first one is really focused on all three of those areas, the community health worker, clinical pharmacist, and behavioral health, and really recommending that DHHS, CMS identify and implement mechanisms for involvement of these team members in existing and future value-based models of care. So that's a broad recommendation. The second recommendation is specific to community health workers. Recommend that CMS optimize the ability of CHWs to assist in improving the care for people with diabetes by the following approaches, and here we get into some specifics that we really want CMS to build on their 2013 final rule to expand the scope of Medicaid reimbursable services by CHWs to include not just social determinants of health, but also behavioral and economic support as part of covered services, and in particular to enhance use of CHW services across states, have CMS develop specific guidance clarifying that Medicaid funding is available for CHWs to address social determinants of health building on some language from January 7th, 2021, where they have a roadmap of how CMS can address social determinants of health. The second is to clarify that CHW qualifications should focus on life experience, interpersonal skills as a natural helper, and community membership as opposed to formal education or clinical training. The next one is require CHW services be delivered in accordance with evidence-informed standards for CHW programs, such as those being developed by the NCQA. And this last bullet, we're having some discussion around the Z codes. Right now we have allow expansion of Z codes. Z codes are the codes that CDC develops that can address, the code can list the specific social determinant of health. And so allowing expansion of those codes to cover more social determinants of health categories so CHWs and other healthcare professionals can better document their activities. So those are some of the, I think the fourth bullet is the main one that's changed. I think all of those others have been there, but we've clarified the language a little bit to try and make this some broader recommendations with sub-bullets. I don't know if any questions about, I'll move on to our other reimbursement ones, but maybe any questions about the wording or these particular recommendations.
Yeah, this is Dean. I had, sorry, I'm echoing here. One point to make and one recommendation. First of all, I'm very, very appreciative of seeing this recommendation. I'm wondering whether there's a way that the language can be added or altered to align with sort of the clinic-community linkage stuff that we talked about as background for our subcommittee. And also it is a language that the value-based models of care of CMS is beginning to use. So it might be advantageous to be thinking about folding clinic-community linkage into this recommendation as sort of part of the end game. And then I just wanted to pitch that you include mention of social workers in the first bullet point, particularly for that clinic community linkage piece, although they can also provide one-on-one counseling. That's it. Thank you.
So if I understood correctly, in the first bullet, you're saying thinking of using social workers, and then the second bullet, you were thinking about the clinic to community linkage, or you're thinking about that just in general, more broadly?
I think it could go in however you want to embed the concept of clinic community linkages as one function of what this expanded team-based care can allow.
Great. Yeah, and that may be part of the background too, so I'll think a little bit about that.
Thank you. Yeah, I just don't know. I believe clinic community linkages may be part of the value-based model of care, so it might be advantageous to link it.
Mm-hmm.
Okay,
and I'm thinking about social workers. I mean, social workers get, I mean, part of the reason I think we went into this model or approach was to focus on areas where there are not reimbursement. I mean, social workers do get reimbursed for their, for their services.
I see.
Yes, I was going to point out the same thing. Just so people know, and it's the reason we don't have physician's assistants, nurse practitioners, CVEs, and social workers, et cetera, is that they already have a mechanism for reimbursement. So, Sherry, I agree with you.
Why don't we move on, and you'll see in the next recommendation where we did expand to cover a specific area where reimbursement was lacking.
Right, so this recommendation, Jasmine had been speaking and seeing some wording around this that's being put forth, but really to recommend that CMS add clinical pharmacists to the list of providers whose patient care services, when delivered to patients in medically underserved communities, are covered by Medicare Part B, or grant them provider status, really trying to reach to populations in need. So this is a new recommendation, so I think important for people to reflect on this. And I know Jasmine's having trouble with some of the being heard, but I don't know if you have anything to add to that.
Hopefully you can hear me, but this language is consistent with some proposed legislation that is currently being considered. So out of left field, rather.
Unfortunately, you're cutting in and out, Jasmine. I think what we heard was that this was also associated with some proposed legislation. Sherry, why don't we move on?
And then the last section is really around implementation. And we combined actually some of our programs and research, but just the recognition that translation of evidence-based practices into care often takes a long time, and implementation programs and research can promote that and accelerate uptake of team-based care models. And currently, the federal agencies that do more of this kind of work, such as AHRQ and CDC, are underfunded compared to NIH, which primarily has not been funding this kind of work. So really recommendation that Congress increase funding for implementation programs and implementation research across federal agencies to better translate evidence-based team-based care into practice and test new team-based care models to improve diabetes care and outcomes on a broad scale. And then the next slide is really sub-recommendations or focus areas. And so, again, these were, you guys have seen these before. We've tweaked them a little bit to have that broad recommendation and these as sub-recommendations or focus areas. But that CDC should expand programs to help states integrate community health worker services as they're currently doing in a comprehensive approach that includes economic, social, and behavioral supports as well as clinical and preventive services, and that DHHS should enhance funding to AHRQ through their primary care extension programs and other mechanisms to provide technical assistance to medical practices to implement team-based care, including the roles for CHW, clinical pharmacists, and integration of behavioral health services.
So why don't we go back to the prior slide? These two focus on implementation. This first recommendation is a proposal to increase funding for implementation research, specifically related to team-based care. And the next recommendations, which we'll come to in a moment, deal with actual implementation.
Yeah, this is really for both programs and research. So it's, and I know there was a comment in the public comments about maybe separating, but, AHRQ does a lot of implementation programs, and so does CDC, and they evaluate them. So I think it gets a little dicey when we're trying to separate them too much, but I guess we could consider whether we need to do that at some point, depending on advice we get. But yeah, this is not just research, it's really implementation programs and implementation research across agencies.
And the next slide for review and comment.
Dean, I was actually thinking that we might, you have a bunch of recommendations around research focus areas, and I'm wondering if at some point later we may end up combining some of those. I don't think we'll make those decisions now, but just it might be a way, there might be a way to combine research across some of these different areas and then have focus areas.
Yes.
Okay, thank you, Sherry. Appreciate it. The next set of slides will be presented by Dr. Cal Greenlee and Ms. Ellen Leek on virtual care and digital connectivity. Carol?
Okay, thank you. And this really flows nicely into or from team-based care as well. A lot of new advances in diabetes, knowledge, how to treat different complications, how to prevent different complications, new medications, new technology. And it can take a while for people on the primary care team to catch up with all of that. So there's a tendency and a need to refer patients with diabetes to a lot of different specialty care. There can be long delays in people getting into specialty care, and that adds or worsens the outcome. And once they are seen by specialty care, that can create fragmentation of care with a lot of evidence around the adverse effects of care fragmentation. So virtual care and some of the new things like telemonitoring or telementoring, I should say, offer a way to help increase the capacity of the primary care team to deliver diabetes care best practices and to provide access to specialty care. We had here recommendations around e-consultations, which is one of the ways that most of the changes required in the CPT codes we learned we go through the AMA editorial CPT panel and not through CMS. So we're going to focus on the technology-enabled collaborative learning and capacity building programs. And for those of you who are familiar, this would be like Project Echo. So next slide. The ability to get patients into specialty care is markedly reduced in clinics associated with HRSA and Indian Health Service. A lot of times those patients don't ever get into specialty care for a variety of reasons, sometimes the travel distance, sometimes being accepted into specialty care. And so for these particular federal programs that deliver, or federal agencies that deliver care to large populations of people with diabetes, because they're sort of weighted with the populations that are more prone to getting diabetes and to getting worse outcomes, we specifically recommend that CMMI should fund a demonstration project with HRSA and Indian Health Service utilizing technology-enabled collaborative learning and capacity building models, e.g. Project Echo type model, to support the uptake and implementation of diabetes care best practices among primary care providers and their care teams, including the training of community health workers. And the details are on the next slide. For HRSA, we would like this to be in collaboration with HRSA to provide diabetes or endocrine outreach to small or rural health clinics in particular, and to include a focus on social determinants of health and behavioral health issues that impact diabetes outcomes, leveraging existing academic center hubs to support uptake and implementation of diabetes care best practices, and in collaboration with Indian Health Services, tribal and urban Indian clinics to create supportive learning and mentorship relationships to assist in implementing diabetes care best practice, leveraging existing tribal epidemiologic center and academic center hubs, and these already exist, including for both HRSA and Indian Health Service, includes payment for both hub and spoke participants' time, meaning the faculty, the specialty care faculty, and the primary care team participants, including the team members, not just the clinician, using a shared service approach in collaboration with entities such as Project Echo, who have appropriate expertise for training on telementoring, provide infrastructure, and help provide the data collection, and then to do the data collection and analysis of interim data such as clinical quality metrics, utilization such as ED visits and hospitalizations, and cost effectiveness. So this is specifically to help close that gap between the delay in primary care team capacity around diabetes and access to specialty care.
So why don't we stop and solicit comments and feedback?
While we're waiting, I will say that neither HRSA nor Indian Health Service both of them are very interested in this. Both of them would like to expand. This is expand this telementoring capacity. We are asking for money specifically around diabetes, but neither HRSA nor Indian Health Service had the ability to do the administrative component of it, and that's why we moved that to CMMI.
John Boltry here. I like the recommendations in the first one with the or endocrine. That's pretty broad and might leave some of the readers a little confused.
We can remove or endocrine and just have diabetes, because that would pull in nephrology, cardiology, neurology, podiatry. So we can, we had received that from HRSA when we were working with HRSA, diabetes or endocrine, but we can, to remove confusion, I think we can remove endocrine.
Or you could say, and related to endocrine, to include those that you mentioned.
Carol,
I'm
is
excited.
the,
Go ahead.
sorry, is the hub and spoke model limited just to kind of endocrine specialty, or could you envision behaviorists, psychologists or psychiatrists also being part of the eligible specialist?
Oh, absolutely. No, absolutely. Diabetes educators, behavioralists, yes. Yeah.
Yeah, Jean, the concept is to improve care for people with diabetes.
What?
I'm sorry, what I was saying is that the intent is to improve the care of patients with diabetes across all disciplines that touch diabetes.
Right.
Thank you.
And to provide a mechanism for helping community health workers become more familiar with the whole picture of diabetes. And so to utilize this as them being part of the team, and also this is a mechanism for training as well.
Okay, why don't we move ahead?
Okay, people with diabetes do have a high burden of care. They are expected to have fairly frequent visits with a variety of different types of care providers, from their primary care team to the different specialty care that we have just mentioned. And so the expansion of the ability to utilize telehealth was very beneficial to people with diabetes, especially to people with diabetes in the underserved areas where they may not have access to specialty care without very long or difficult travel, time off work, extra cost to them. And so the ability to not only get a visit with their primary care team, but also with the specialty care that they need through telehealth has been very, very beneficial to people with diabetes. So this, we've heard from CMS that they don't have the authority to continue the waivers for the COVID-19 public health emergency around these aspects of telehealth. So we recommend that Congress should remove the geographic and originating site restrictions so that CMS can provide access to telehealth services as appropriate, make permanent the ability for federally qualified health centers and rural health centers to provide services by telehealth, maintain coverage for audio-only visits as necessary to comply with the executive order on advancing racial equity and support for underserved communities, and as you heard in Jasmine's recommendations, also for DSMES, DSMT. So this is open for comment. Hopefully that means you agree. I think we can go to the next one unless there is comment. So digital connectivity requires more than just laying the fibers. Laying the fibers is necessary but not sufficient. People need to adopt the use of broadband. They need to subscribe. They need to utilize it. In addition, FCC has done some studies showing that the degree of connectivity within a community is associated with a variety of different health factors, including the prevalence of diabetes. So the less digital connectivity in the community, the higher the prevalence of diabetes. And then they've also shown the reverse. If connectivity increases, that's associated with a lower prevalence of diabetes. And that has, and many other health factors beyond diabetes. That pulls digital connectivity into the realm of being a social determinant of health. The importance of digital connectivity goes way beyond just exchanging an in-person visit for a televisit. It's much more encompassing. And so that leads to our next set of recommendations. To improve connectivity and its impact for people with diabetes, FCC should focus more broadly on digital connectivity to include adoption as well as access, and conduct research to better understand the association of digital connectivity, diabetes prevalence, and improved diabetes health. And then this may go under the recommendation number 1, that this would be, that Dean had under the population health, but FCC, USDA, and DHHS should expand the scope of an interagency MOU beyond the Rural Telehealth Initiative or establish another similar mechanism to bring together the appropriate federal agencies to share information on and investigate the relationship between connectivity and health and the types and extent of digital services required to positively impact health. Currently, FCC, USDA, and DHHS have an MOU around the Rural Telehealth Initiative, and we think that this is a perfect opportunity to do information sharing, discovery, etc., around the bigger issue of connectivity as a social determinant of health. So, open for discussion.
Carol, this is Ellen. The only thing I'd like to add is that we're...
Ellen, talk louder.
I think. Okay, let me try this. I think Jasmine and I are cursed today. Hope you can hear this. I think the MOU, whether it's that vehicle or any other kind of collaborative way in which the FCC, the USDA, and DHHS can work together. I think Naomi spotlighted this on our last call around the work that USDA does. So whatever the venue, we are looking for this kind of federal collaboration.
Right, thank you.
Are there any comments or feedback for these recommendations? Okay, I think that concludes the report of our subcommittee. I want to thank sincerely all the hard work of our subcommittee members for bringing these recommendations to fruition, and we'll look forward to finalizing them for a vote by the full commission. So, Dr. Herman, back to you.
Great, thank you very much, Paul and Carol. You've actually gained us five minutes, which is terrific. I'm going to go ahead now and talk a little bit about the work group on health systems level interventions and the progress there. This work group has been addressing three issues: access to health insurance for people with diabetes, making medications affordable for people with diabetes, and healthcare delivery and payment models to improve care for people with diabetes. The working group has received many helpful public and stakeholder comments, and these have been reviewed and used to revise the work group recommendations. Quite a few of the original healthcare delivery and payment model recommendations as well have now been taken up by the prevention targeted population and the treatment and complications subcommittee. So much of what I was going to say with respect to this third bullet, I'm going to skip over today. But I will focus on access to health insurance for people with diabetes and making medications affordable for people with diabetes in some detail. So if I can have the next slide. Access to health insurance is really, in my mind, the elephant in the room. All of the recommendations for targeted prevention of diabetes and diabetes treatment and prevention of complications depend on people having health insurance and having access to health care. In the United States, access to health insurance is provided through four avenues: through employer-sponsored health care, through the marketplaces, through Medicaid, and through Medicare. And to address the gaps in the current public-private system of health insurance, and as an alternative to repealing and replacing the Affordable Care Act or Medicare for All, we really, I think, need to address the gaps in these four sources of health insurance that people with diabetes, people with prediabetes, and in fact everyone in the U.S. Potentially have. So we need to think about improving access to employer-sponsored health insurance coverage, expanding coverage, increasing the affordability, and stabilizing plans, expanding and improving access to Medicaid, and expanding Medicare coverages. And if I can have the next slide. So I'm going to go through each of these in some detail. The first issue, again, is improving access to employer-sponsored health insurance coverage. The Affordable Care Act requires that employers with more than 50 full-time employees offer health insurance that is affordable and provides certain mandated benefits. Employers who fail to comply pay a tax penalty. At the same time, employers can offer employees health reimbursement accounts that provide sufficient funds to cover 80% of the cost of a silver marketplace plan, with employer contributions made on a pre-tax basis and employee reimbursement being tax exempt. So next slide. So based on this background, we recommend that the tax penalty be removed for employers that do not provide employees with qualified health insurance coverage, but those employers be required to provide funds to employees' health reimbursement accounts to cover the cost of silver marketplace health insurance policies for those employees and their dependents. A second provision would be to increase the eligibility for dependent coverage from age 26 to age 30. Allowing young adults to stay on their parents' health insurance to age 26 has proved incredibly valuable in terms of getting young people insured, and expanding that to age 30 would cover many people with type 1 diabetes and more people now with type 2 diabetes who are transitioning from their parents' insurance coverage and trying to get established and get health insurance on their own. The third recommendation is that high-value services, including certain preventive services, assessments, and treatments for diabetes, including diabetes self-management, education and support, medical nutrition therapy, behavioral health care, monitoring and insulin delivery devices, diabetic retinal exams, and insulin be provided free or at very low cost through employer-sponsored health insurance, and non-medical switching be curtailed so that diabetic patients using previously approved products not be forced to switch to different medications or devices due to changes in formularies. But again, I think the key recommendation here is that employers that don't want to provide health insurance actually provide funds so that their employees can get insurance coverage through the marketplace, and that the employer-covered insurance cover dependent children or young adults up to the age of 30. The second piece then, if I can have the next slide, is expanding coverage, increasing the affordability, and stabilizing premiums for individual marketplace health insurance plans.
Can you hear me? This is Sherry. This is a lot to cover without any feedback. I mean, can we say something briefly about the last slide? Or do you feel like it's still connected to what you're...
Yeah, I was really going to try to get through all of this. So if you can jot it down, if you don't mind, I'd like to get through all of the 4 pieces and then take comments. Okay. So the second piece refers to the individual health insurance marketplaces. These provide a source of insurance for workers without employer-sponsored health insurance and those with incomes below 400% of the federal poverty level but above the threshold for Medicaid eligibility. Under the Affordable Care Act, premium subsidies are provided for individuals and families with incomes between 400% and 250% of the federal poverty level, and waived for those with incomes below 250% of the federal poverty level. Unfortunately, changes in federal policies resulted in reductions in spending on advertising for open enrollment and for in-person enrollment assistance, and shortened the open enrollment period. In addition, federal cost-sharing reduction payments were terminated, leaving many low-income individuals and families not otherwise eligible for Medicaid without health insurance. In addition, some individuals who qualified for subsidies chose not to enroll in coverage even when the subsidies would cover the entire premium costs. And finally, the high-cost individuals enrolled in marketplace plans can destabilize the cost of the plan and threaten the marketplace. So the second set of recommendations are related to marketplaces, if I can have the next slide. And these are to restore funding for advertising and consumer assistance for marketplace plans and increase the length of the enrollment period. Second, to establish special enrollment periods for individuals who lose employer-sponsored health insurance or whose incomes change dramatically during the year due to changes in employment. Increase market risk pool support to ensure adequate offerings in all areas of the country. Restore cost-sharing reduction payments for individuals with incomes below 250% of the federal poverty level. Expand the availability of premium tax credits to individuals and families with incomes as high as 600% of the federal poverty level who do not have access to employer-sponsored health insurance coverage. Give states the authority to auto-enroll subsidy-eligible individuals into marketplace plans, provided the premium is less than or equal to the amount of the individual's premium tax credit. And establish a federally funded and state-administered reinsurance program for high-cost individuals enrolled in marketplace plans. The third set of recommendations relates to Medicaid, and if I can have that slide. Access to Medicaid would be facilitated by expanding Medicaid eligibility to all states to individuals with incomes less than 139% of the federal poverty level, and permitting states to offer continuous 12-month eligibility for adults would also facilitate coverage. As you know, only 38 states have currently expanded Medicaid, so next slide. We would recommend that financial incentives be provided to encourage all states to expand Medicaid, qualify diabetes as a disability eligible for Medicaid buy-in for low and moderate income individuals, cover telehealth services including video and phone and audio-only delivery, expand coverage for needed supplies and devices, especially for people with type 2 diabetes and gestational diabetes, cover all forms of insulin including pens, vials, and inhaled insulin and other insulin products that may be approved in the future, and allow adults enrolled in Medicaid to be offered continuous 12-month eligibility. But again, here the main point is expanding Medicaid to all 50 states.
And Bill, if I could just comment that probably the best done study of the effect of insurance on diabetes outcomes is the study of those states that expanded Medicaid as part of the Affordable Care Act versus those that chose not to, and the disparities in diabetes outcomes were quite significant.
Yep, there's certainly a lot of evidence along those lines. And the final piece, just moving on now, is with respect to Medicare. Medicare has been extremely successful in ensuring access to care for Americans 65 years of age and older and those with disabilities. Access to care could, however, be improved. And the next slide shows a number of specific recommendations. These are more sort of on the edge and have less to do with access to care, but they include things like facilitating comparison among traditional Medicare fee-for-service, Medicare Advantage, and alternative payment model Medicare plans to provide estimates of cost sharing for enrollees, developing and implementing a more streamlined enrollment process for dual Medicaid and Medicare eligible beneficiaries, making permanent waivers established during COVID-19 public health emergency for things that we've already discussed. Next slide. But also to continue to cover 90-day supplies for prescription medications and diabetes testing supplies. And finally, expand Medicare coverage for obesity treatments for the management of diabetes. So treating obesity is a treatment for type 2 diabetes, and there are three specific things that we'd recommend. One is expanding Medicare Part B coverage for outpatient medical nutrition therapy for obesity and prediabetes. Currently, Medicare Part B only covers medical nutrition therapy for people with diabetes. Second, improve coverage for intensive behavioral therapy by expanding the range of providers that are reimbursed for these services. Currently, Medicare only covers these services when provided by a primary care provider in a primary care setting. And finally, revise Part D plan guidance to cover all FDA-approved anti-obesity medications in conjunction with intensive behavioral therapy. Currently, Medicare Part D does not cover FDA-approved weight loss medications. So I'll stop at this point and actually go to Sherry, who I hope wrote down her comments. Sherry, did you have?
Yeah, I got two of, so yeah, the first question I had was just this non-medical switching of, it was probably one of the first initial slides of medication
Right.
based on like, I think insurance changes, right?
Yes.
So is that recommendation meant to be through like CMS if somebody's switching to Medicaid or to Medicare from another private, or is that meant to be within Medicare plans?
So it was actually included under employer-sponsored health insurance, where I think it is the major problem, but it is a general problem. I think it's probably most acute problem where formularies change every year depending on who gets the contract for insulin or for the statin. But I think it's worth considering because it has a huge toll in terms of medication adherence as well as patient and provider.
Right. So I guess I'm just trying to think about how this is put in place based on the recommendation, because it's a big issue, but it's not just federal plans, right? So are you saying if somebody's switching, I guess you put it within the employer-sponsored health insurance plan, so you're talking about the federal plans within the employer-sponsored space.
Right, and we would obviously have fewer recommendations to make in that arena. But how do people think it would apply to other drug plans?
Bill, this is Carol. In the initial things that you sent out, you had a lot of things about increasing competition around the drug prices and generics, etc.
Yep, that's actually coming up next.
If somebody lowers their price and you're required to keep the patient on the higher priced one, there's going to not be as much motivation for competition. As a clinician, it's a total mess when you have to switch from this GLP-1 to another one, or even from the same generic but a different company, and you have to make sure the patient's okay with that and doesn't get confused over the color of the pill. And I understand the hassle factor, but what are the unintended consequences of saying you can't? And also, it seems to me like it's a bit out of our scope, if not a lot out of our scope, especially to be addressing employer-based plans. But nonetheless, what are the impacts on the recommendations around competition if they have to adhere to whatever the patient's taking and they're not able to take advantage of the lower prices?
Right, so I think that would be an issue.
Yeah, I struggled with this bill at the beginning because I wanted us to make some kind of recommendation around this, and I think, Paul, you had suggested something that was broader than just the employer plans, and I'm forgetting what it was. I don't know if you remember.
I don't remember that specifically, Sherry.
Okay. It was something around, like, at least for certain groups, is there a way to have some kind of unified, formulary, which doesn't fully get at this issue of switching, because, even within a unified formulary, they switch based on, what deals they can do. So I think it's just a hard thing to put into practice, and I guess I'm not sure, how that would really work well.
And I believe this came from some of the public comment that we received, but I haven't specifically thought it through. I think we do need to give it more thought.
Yeah.
Are there other issues that you had, Sherry? Oh, go ahead.
No, go ahead, Bill.
Sherry, did you have another point, or Dean, did you want to go ahead? I think Sherry had a second.
I think can go, and I can come back to the other one.
No, Sherry, you have the floor. Go ahead.
This is really small, actually. It's kind of minor. I think on one of your slides there was it was like 104, there's, I think, some duplication of recommendations of things. It felt like there was some duplication of recommendation around some of the things we're doing. And I can't remember, I put the slide 104 because I can't remember what the actual recommendation was, but I'd have to go back to that slide.
Can you go, Jennifer, can you go back to slide 104?
It was cover the telehealth services, including video, phone, and audio-only delivery. You have like some sub-bullets of things. I don't know how much or to what extent those, maybe it was just that one. But just,
right, and there is some overlap, and so some of these things, you're right, some of these things can certainly be deleted here. Dean, what did you want to go ahead?
Thank you. Yes, I wanted to get to the last slide. Perfect. The revised Part D. Sorry, one before that. Yeah, the revised Part D. To me, it feels like for us to recommend covering all FDA-approved anti-obesity medications, they would need to have also demonstrated efficacy in preventing diabetes. I guess I worry a little bit about us making a recommendation about something that prevents obesity if it doesn't prevent diabetes, which is the case for, there is a subset of anti-obesity medications that have been shown to prevent diabetes, and then a whole bunch that haven't been.
Yeah, so the evidence, so the American Diabetes Association now in their standards of medical care have a chapter on treating obesity for the management of type 2 diabetes, and they go through intensive lifestyle interventions, pharmacotherapy, and bariatric surgery. And there are recommendations in terms of achieving weight loss with anti-obesity medications. If you don't achieve, recommendation always is to stop them, but the evidence is pretty strong that you can either cause diabetes remissions or improve the controllability of glycemia with a 5+% weight loss. So I think the evidence is pretty good for most of the FDA-approved medications.
But is that evidence a result of the anti-obesity medication per se, or is it the 5% weight loss was associated with a reduction in diabetes or improved metabolic parameters? Do you know what I mean? Is the medication the mediator?
It's the latter, so it's the weight loss, but the medications are only recommended if people starting them are able to achieve and maintain a weight loss.
I just don't know how one can know that a priori, that your patient's going to be able to achieve and maintain it.
Well, so the approval is for 3 months of initial therapy, and if the person has not lost weight, then the drug is pulled.
I see. So I'm wondering whether the recommendation needs to be a little bit more specific then.
Yep. What do other people think?
Well, this is
I think that would make sense, Dean, if you were confused.
This is Naomi. I do agree with Dean, but in general, for this section, while I think it's a laudable goal for us to comment on insurance and support for sustainability of interventions for prevention, I just wonder whether or not this should, are you thinking of this as being one of the overarching things under which all of the other more specific subcommittee recommendations that dovetail on issues related to reimbursement and cost and so forth? It almost seems like not quite connected enough to me.
Yeah, well, so some of the things that got added, like the coverage for FDA-approved anti-obesity medications, were added as a part of public comment. I think, to me, again, I think the main thing is that people at risk for diabetes, people with diabetes, need access to health insurance. So, there really are not major recommendations related to Medicare for that, because people, when they become 65 or have disabilities, get Medicare. I think the main recommendations relate to the marketplace plans as an alternative for people who can't get employer-sponsored health insurance, and Medicaid, which is specifically Medicaid expansion. So I think that maybe should be where we primarily focus, and I think that would make it clearer what we're trying to do.
I feel like we should say that it's critical, that we should make a strong statement in the report because it is critical, And I'm not saying any of these are bad recommendations. I'm just thinking it takes it away from what we were supposed to do, and I think it reduces the chance that our more diabetes-specific changes that we're asking for, which are big changes in their own right, it reduces the chance that any of them are going to go through. So I think a strong statement is needed and maybe a supplemental paper, but I'm really, really concerned about going this broad when we weren't asked how to reform healthcare. We were asked specifically how to help with the diabetes issues. So I'm going to just go on the record as being worried about this, and I think it's not that it's what you're saying is wrong. It's not that I disagree, though I did worry about what that does to competition, but I am worried about the impact on all of our other recommendations, and I would prefer if we just made a really strong statement as opposed to telling employer-based plans how to be changed.
But Carol, this is Dean. I'm just wondering, I mean, to me, a recommendation regarding health insurance, including some of the details that Bill has laid out, could very well fall under the treatment and complications section of the report. I'm not suggesting that you need to write it or edit it or anything, but in terms of how it flows and the logic therein, I don't see this at all as inconsistent. There may be a level of detail regarding the, you know, telling Congress or telling agencies how to get the job done as opposed to, you know, what we want them to do overall. But I guess I'm not seeing what is irreconcilable in these recommendations.
I think it's too broad. Well, first of all, I would want to know the full vetting and the due diligence and everything around it. We've spent 2 years working and reworking and refining and looking at unintended consequences and where it best fits and is it within the scope of federal agencies and which agencies, and I'm just going to express my concern, not saying that insurance isn't important, not saying that affordability isn't important, not saying that some of these changes aren't needed. I'm just not thinking it's the job of our commission. I don't think Congress is going to do any of this because the commission asked to look at diabetes said that we need to expand Medicaid. In my opinion, I mean, there have been lots of attempts at expanding Medicaid, and one of the things that just came out is, again, offering states incentive to expand Medicaid. And so the Medicaid isn't going to be expanded because we put it in our diabetes report. I'm probably not making sense to you, Dean. I just am afraid that we're going to dilute out our other recommendations and reduce the chance that they might get enacted, where it would really, really help people with diabetes to get some of those enacted. Because I don't think anybody's going to change insurance based on what we say, to be honest.
Well, I mean, we've had this conversation before, and I think there are two issues that you're raising that I think we want to make sure are mutually exclusive. The first is whether these recommendations have been appropriately vetted and are accurate in terms of content and authority. And then the second is, and I think that's a very, very valid point, and we should support Bill in trying to get that answered. The second point as to whether something is strategic or not to include because it might undermine other recommendations, to me, feels like as long as the recommendation is within the duties of the NCCC, it is not our job to make a decision as to whether an evidence-based recommendation that could help people living with or at risk of diabetes would be acceptable to Congress. I mean, if it's not acceptable, they can ignore it. But to not include something that is so clearly based in evidence and experience would feel more problematic with respect to what our charge is and how the duties are described. Although I understand where you're coming from, I feel like it's a important distinction to make and a decision we need to communally come to.
Dean, this is Paul.
Yeah,
I concur with the points that Carol and I think Naomi was alluding to earlier. I think you articulated nicely the kind of the two branch points that this presentation is putting in the fore, and that is, one is, have the recommendations been vetted, and are they based on evidence, stakeholder input, subcommittee work, et cetera, as our other recommendations have been. And the second point is, are they within scope? With regard to that latter, I have some concerns that they are a bit out of scope. And now, this may be something that others might disagree with, and I respect that. What I'm more concerned about is not the merits of the recommendations with regard to their impact on people who may or may not have diabetes, but whether or not they extend beyond what people might view as the reach of the Commission to now issues related to healthcare reform in general, which we all agree is very important, and as Carol alluded to, could be addressed by a simple, very bold statement that none of what we propose below is going to be effective unless people have adequate health care. But to have specific and targeted interventions, some of which may or may not impact, may or may not be impacted by federal agencies, is to me also a concern.
Paul and others, this is Shannon. Are we specifically talking about the recommendations that are on the slide? And that, is it the overreach of the, for example, coverage of prescription medications? Just trying to sort out what the concern is.
Like the first step.
So Shannon, what I would like to focus on is the gaps in insurance coverage among employer-sponsored marketplace Medicaid and Medicare coverage, and make the point that access to health insurance is an enormous topic that is absolutely critical to each of the recommendations of the targeted prevention, targeted population treatment, and complications. And, you know, I started with the analogy of the elephant in the room. Health insurance, it's obvious to everyone that it's critically important, but it's often ignored because it is controversial or considered to be potentially dangerous. And I don't think we should fall into that trap. I do think we need to call out the issue that everyone with prediabetes, everyone with diabetes, needs to have health insurance coverage or the option for health insurance coverage. And I think to do less than that, I think, is to ignore the elephant in the room.
Yeah, I would just add,
call it out. I just am concerned about the scope of our recommendations.
Yeah, I was looking at slide 102, which I didn't comment at all on, Bill, because it was such a list of recommendations that I had to just think through. But like the last two bullets of that slide are I would love to see some of it just gets into very specifics of things that, like, do we have evidence on all these things that they improve outcomes for people with diabetes and prediabetes? So there's just a lot here. So, and I don't really know the implications of the last bullet at all. So we're moving high-cost people from the marketplace to some state insurance plans. So all of a sudden, the state and federal government now have all the.
No, so it's basically a reinsurance plan for marketplace plans, so that it's a stop loss. So that if a marketplace plan has catastrophic patients, that they are not bankrupted. It's pretty standard in health insurance plans.
Right, but yet somehow there's a lot of recommendations here that I don't really understand. So I think we either need to clarify, maybe I'm the only person on the committee that doesn't understand, but I think it's hard to say whether we should review them when I don't understand, how to.
Well, what I think we need to move on at this point. I'm getting an echo, so people not speaking could mute. But what I'd like to do is perhaps set up a meeting for people who would like to pursue this, that we could have an hour or two to deal with this and the other recommendations in more detail. So Jennifer, perhaps you can set up a call for folks to discuss this.
This is Naomi. Just as a final thing, I do think that this is an important thing to cover, and I think it could be incorporated as part of the overall report, but not necessarily stand out to the level of details and sort of micro suggestions that are being made for things that, as many of the others have said, we may not have sufficient, evidence to support that this will work nationally. So I think it's a laudable effort for all of us to try to incorporate all of this, but just whether or not it should stand on its own, I think will, as Carol
I'm not hearing you, Naomi.
I just want to make sure I understand, Naomi. I think you're saying we should have recommendations around health insurance.
Yes.
Where they are situated and how detailed they need to be is an open question.
Correct. Because right now it comes sort of at the end.
Is that correct?
Yes, that's correct. Can you hear me or not hear me? Sorry. But
We
that's
can hear
correct.
you now, Amy.
I can hear you now. Yeah.
Yeah.
And I think that's the topic that maybe we can have an offline conversation about to get people who've commented today together to discuss offline.
Great.
Okay. I'd like to go ahead with the next part, which is the issue of making medications more affordable. And by way of background, for people with diabetes, access to insulin and other life-saving prescription medications can be facilitated by controlling their cost. And we've made a number of recommendations to improve access to insulin and other life-saving prescription medications for patients with diabetes or at risk for diabetes. And these recommendations are developed around these 5 bullet points, which represent issues that make medications unaffordable or less affordable for people with diabetes. So the issues that need to be addressed include encouraging competition in the market for generic drugs and biosimilars, reviewing the incentives provided to brand manufacturers to reward innovation without creating unnecessary barriers to competition, increasing the flexibility of the federal government to negotiate drug prices, increase transparency in the pharmaceutical distribution system to ensure that financial returns are justified across all parties, and reduce regulatory barriers to value-based insurance design to better align the out-of-pocket costs of drugs to their benefits and promote the Medicare Part D senior savings model. So I'm going to go through each of these in a little bit of detail and provide specific recommendations to address them. The first is to encourage competition in the market for generic drugs and biosimilars. The issue here is that although generic drugs make up 86% of prescriptions written in the United States, problems arise when there are too few suppliers for an unpatented drug. This may result in weak competitive pressure and high prices. So next slide. To ensure that generic drugs are available and affordable, we recommend pay-for-delay arrangements that block access to lower-cost generic drugs be curtailed to address anti-competitive behaviors in gaming. And second, that the 180-day exclusivity period given to generic manufacturers to promote an incentive for taking the financial risk associated with being the first to file generic manufacturer be revised to close loopholes that limit competition beyond the 180 days without a reasonable justification for the delay. The second issue is the incentives provided to brand manufacturers. Generic drugs represent the majority of drugs in the marketplace, but brand name drugs are the primary drivers of drug spending. Unlike the generic market, manufacturers' pricing power is based on protection from competition that is intentional and designed to provide an incentive for pharmaceutical research, development, and innovation. Next slide. To ensure that drug discovery incentives are adequate but not excessive and to encourage competition, we recommend modifying patent laws to discourage manufacturers from applying for multiple patents on a single drug and from making slight modifications to old drugs to obtain new patents to extend a drug's patent protections, to curtail shadow pricing for drugs with few manufacturers such as insulin, to reduce the period of market exclusivity for biological products from 12 years to 7 years, and to remove barriers to biosimilar market entry like the biosimilar insulin analogs. Next slide is related to increasing the flexibility of the federal government to negotiate drug prices. By statute, Medicaid is permitted to negotiate drug prices, and by doing so is able to provide beneficiaries with an extensive choice of medications at low out-of-pocket cost. This is in sharp contrast to Medicare Part D, which is currently prohibited from negotiating prices. So next slide. We recommend that all federal drug benefit programs be given flexibility to negotiate medication prices with manufacturers and pharmacy benefit managers to capitalize on their market shares and volumes. And similar to Medicaid, these programs should elicit best price requirements and protections against medication net price increases greater than the rate of inflation. Next slide. The next issue relates to transparency in the pharmaceutical distribution system. For every $100 spent on retail drugs, $41 goes to parties in the distribution chain, wholesalers, pharmacies, pharmacy benefit managers, and insurers. The growing difference between the list price and the net price of a drug reflects negotiated rebates and discounts put into place to influence formulary placement among competitive brands within a class. High list prices disadvantage patients without insurance who pay the list price or pay co-insurance based on the list price of the medication and impact both medication adherence and health outcomes. To address these issues, greater transparency and simplicity should be introduced into drug pricing to eliminate distortions that are currently beyond individual payers' ability to address. So next slide. We recommend that transparency be increased throughout the pharmaceutical supply chain, especially in the pharmacy benefit manager market, and all negotiated rebates and discounts for prescription drugs, including insulin, should be passed on to the patients at the point of sale during the deductible phase. A person with diabetes should never pay more for a medication than a plan would pay if the plan were paying 100% of the cost. And the final topic in this is on next slide relates to value-based insurance design. Value-based insurance design, or VBID, aligns patient out-of-pocket costs with the value of a health service regardless of its actual price. VBID plans encourage patients to use high-value medications such as insulin by lowering its cost to the patients. Tools employed by VBID include covering high-value treatments without applying their costs to the patient's deductible, known as pre-deductible coverage, and covering high-value treatments without any patient co-insurance or co-payment. So in this arena, we recommend insulin and other high-value treatments be covered without applying their costs to the patient's deductible. So again, pre-deductible coverage, and insulin and other high-value treatments be covered without any patient co-insurance or co-payment. Insurance practices that force patients to choose between affordability and quality should also be curtailed. This includes step therapy or fail first policies that require patients to try the least expensive drug in a therapeutic class before being eligible to receive the medication that the prescriber believes to be the best for the patient, and also to simplify prior authorization requirements. And the next slide. And a good example of this is actually the Part D senior savings model. CMS regulatory barriers currently restrict value-based insurance design that might better align the price of medications and patient out-of-pocket costs to their benefits. In January 2021, the CMS Innovation Center launched a promising new model for pharmacy payment called the Part D Senior Savings Model. The model is testing the impact of offering beneficiaries an increased choice of enhanced alternative Part D plan options, including lower out-of-pocket costs for insulin. The program is available to both beneficiaries who receive Part D coverage through standalone prescription drug plans and Medicare Advantage prescription drug plans. Beneficiaries have broad access to multiple types of insulin at a maximum copay of $35 per month, per insulin per month, in the deductible, initial coverage, and coverage gap phases of the Part D benefit. So next slide. Given that this program has the potential to provide stable, predictable copays for the insulins that beneficiaries with diabetes need throughout the different phases of the Part D benefit, we recommend ensuring that eligible beneficiaries are aware of the Part D senior savings model and making enrollment easier to navigate for beneficiaries, encouraging widespread testing, rigorous evaluation, and if effective, broad implementation of the Part D senior savings model, and exploring and facilitating broader implementation of alternative payment models for medication benefit design, including value-based pricing, where the formulary placement of a drug and its cost to patients is inversely related to its health benefits. So that's it in terms of making medications affordable. Any comments on that?
So again, this is Naomi. Oh, go ahead, Sherry.
Go ahead.
Go ahead.
There were two things that struck me. One is that some of the language about being able to negotiate for lower prices is going to run in contrast to some of the other conversations we had about, the not switching medicines that people are on. So I know we're going to think more about that, but that strikes me. And then the second thing was, there was something. I'll have to go back to one of the other slides. So it was one of the recommendations. I'll go back while Naomi talks.
Thanks. No, sorry. Again, I think these are, wonderful, broad ideas that dovetail well with many of the subcommittee's recommendations. But I would hope we could find a way to incorporate it in rather than having it be a separate sort of set of recommendations, because it does tie into a lot of what we were discussing earlier with respect to access, affordability, equity, and so forth. Yeah.
Yeah, it's sort of it cuts across both treatment or prevention targeted population to some degree, though it really is mainly a treatment and complications issue, I think, here. And that would be fantastic if it could somehow be integrated there. I don't believe that this one needs to stand alone.
Bill, this is Barbara. I just have a question about some of the specifics of the recommendations. I mean, I think, we're all, in agreement that this is a huge problem that needs to be addressed. But in terms of balancing, the incentives for developing new drugs, which, are enormous, especially considering that most new drugs fail and never, make it to market. For example, is that recommendation to go from 12 years to 7 years, is that based on some analysis that's been done?
So it puts it more in line with the patent life for chemical entities as opposed to biosimilars. I don't know if Bill wants to comment on this as well from the FDA perspective.
Hey, Dr. Ehrman, I think you're talking about the new molecular entity exclusivity for drug products versus the new biologic products exclusivity that's granted at the time of approval. I think
correct.
Yeah, I think that's where there's a difference. Not being part of the whoever designated or legislated that exclusivity, my understanding is that biological products are more challenging to develop, and so I think that's why they thought extended exclusivity compared to the small molecular, new molecular entities that are the small molecule drug products that people are more familiar with. So I think that was a consideration, but I obviously can't speak with any certainty, having been involved in that decision making or that recommendation that ultimately led to that. Yeah.
And this may be more of an issue in terms of patent, changing the product and extending patents and pay for delay, and those issues as well may have been more of an issue there than the 7-year versus 12-year exclusivity.
Bill, this is Paul Conlon. I think in this section, the recommendation that resonates with me and probably with many others relates to affordability of insulin. I think that there would be broad consensus for such a recommendation, and I think that is one that stands out as having great relevance.
Good, and that is sort of the recommendation that this whole series of recommendations is built around, but it does highlight, I think, the 5 levels of problems in the medication pricing.
Right. So I think the broader recommendation stands. There are many other entities, including organizations, that have tried to look at this and find out, what the various mechanisms are that lead to insulin prices being elevated, and no one has really identified what a specific cause is. So I'd be curious to know if you've found specific areas that contribute to that are actionable by the federal government.
Well, so a lot of these that are listed actually come from that analysis, like shadow pricing and some of the patent issues and pay for delay have all emerged from part of that.
So, Bill, this is Sherry again. I also agree. I think this is great because cost is a huge barrier for patients getting medications. I guess I'm looking at slide 118 where it's insulin and other high-value treatments be covered. And there's I guess one question is who will determine the high-value treatments, or how will that be determined? And then the other question is, it's sort of, it looks like it's recommending in the third bullet to get rid of step therapy as well. And I guess I'm just, any thoughts about, these are very expensive medicines, right? So how do we do that in a way that's, where does that cost go to? And have there been thoughts about some of the pushback around this that we may run into.
Yes, so both the non-medical switching and the step therapy and the issue related to prior authorization came from public comment. As I've thought about them, I wanted to put them out for this group to discuss and kick around. I think that they are actually probably not consistent with some of the other recommendations, and my inclination would maybe be to pull back on those recommendations. Because again, if prior authorization or step therapy is the alternative to pharmaceutical marketing, I suspect that pharmaceutical marketing will win in terms of promoting new drugs, and it may make more sense to maintain step therapy as a cost control strategy at some level anyway.
Hi, Dr. Herman. This is Bill Chong. I have a question on the recommendation regarding transparency of pharmacy benefit managers. I'm just trying to better understand what you think that recommendation will have an impact on and how that will work.
Yeah, so the negotiations between insurers and pharmacy benefit managers and pharmacies and manufacturers are all confidential. I think shedding light on those arrangements would help in terms of increasing the transparency and allowing people to understand where the money is going. As I pointed out, I think in that slide, about 40 cents on the dollar is eaten up in the distribution system, and I think there needs to be a better accounting for that.
Just to clarify, this is Carol. You already know my opinion that we should focus on outpatient costs, out-of-pocket costs to the patient, and that's where we should really focus as opposed to patents and things like that. So I've shared that with you already. But things like curtail shadow pricing for drugs, which you manufacturers, remove barriers to biosimilar market entry. Who do we direct that to? Like, who controls that shadow pricing now? And how do they control it?
Well, it seems like it would be an anti-competitive practice if you look at the price changes for insulin glargine and Levemir insulin over time. They were in lockstep over a series of years, one after the other. And whoever regulates anti-competitive pricing, I think, would have some authority there. I don't know, Bill Chong, if you can help me again here. Who would oversee that? I don't know if it would be the FTC. I'm not sure who that would be.
I think that might be the Federal Trade Commission, but I guess I mean I don't work on that. I'm not familiar with that side enough to say, but I think the FTC would probably be the agency, but there may be a burden of proof that is difficult to kind of to demonstrate. But I think the FTC would probably be the sort of the agency that kind of recommendation would be directed at.
But it has been recognized as an issue, and it certainly could be addressed.
I'm going to jump in here also. Treatment and Complications had wanted to make a recommendation that there be some sort of task force, Dean, for lack of a better word, I'm just going to say task force, to determine which secondary and tertiary prevention services and treatments for people with diabetes should be pre-deductible, or, just like a pap smear for primary prevention where it's covered. And that would pull together a lot of the different things that you're recommending here, Bill, like which that would do diabetes education. Right now there's cost sharing for that, and that keeps people from getting that. Diabetic eye exams and diabetic foot exams, if you have 20% cost sharing, that limits those. If there some of the medications that really add value could be determined in that too, and that would pull together a whole lot of the disparate recommendations that you have into saying there needs to be some sort of entity to help determine the valuable secondary and tertiary preventive services and medications, and that might even fall under that Office of Diabetes, I forget what it's called now, that when we have in, Dean, help me, what's the Office of Diabetes something that we're recommending to be at the executive level?
Yeah, Office of the National Diabetes Policy, yeah.
Yeah, sorry, I can't remember. But, so I'm just going to say that I could really get behind supporting that as opposed to some of the things that seem to be, to me, way beyond diabetes.
Yeah, no, I think that makes sense, and there are good data for self-monitoring of blood glucose supplies, diabetes self-management education, and diabetic retinal exams that out-of-pocket costs decrease appropriate utilization. So that's pretty well established, and I think that would be a reasonable approach to trying to use that organization to define those things. I'm looking at the time now, and I realize that I've run over fairly substantially. I want to just go to the last bit, the last piece about healthcare delivery and payment models, and here just emphasize the point that chronic illnesses, including diabetes, require proactive treatment to prevent complications and improve clinical outcomes. And the current healthcare delivery and payment models, including fee-for-service reimbursement, do not adequately facilitate proactive chronic disease management. And I think there are recommendations, that many of which have already been made, related to implementing new diabetes quality measures as a method for quality improvement and improving support for new healthcare delivery and payment models. And if you can just go quickly to the next slide. And go to the next slide. In terms of quality measurement, as I tried to pull this together, there were 3 and potentially 4 recommendations I wanted to make. One you've already heard, which was the quality measure for primary prevention of diabetes with the 3 components as recommended by the ADA. I really do really think that this would begin to move the ball in terms of diabetes prevention on a population level. The second thing I thought we ought to think about is measurements of over-treatment, such as over-treatment in elderly patients with multiple comorbidities, in whom the risks of lowering their A1C are probably greater than the risks of, or the benefits are greater than the risks of hypoglycemia treatment burden and cost. The third point I wanted to make was related to modifying quality measures so that they were more consistent across federal agencies and payers. And if I can have the next slide. And let me see, in the next slide. And another potential quality measure is actually shown as the first bullet here, which is measuring the appropriate use of diabetes self-management education and support at 4 critical time points, including at the diagnosis of diabetes annually when patients are not meeting their treatment targets, when complicating factors develop, and when transitions in care and transitions in life occur. So I think we should probably give some thought in terms of quality measures to improve the processes and outcomes of care. If you can go on to the next slide, and the next slide, and the next slide. Oops, go back one, I'm sorry. And go back again. Another issue is shown in the first and third bullets on this. And one thing we might think about in terms of treatment and complications is providing monthly care management payments to support practice redesign and care delivery, and providing additional support to practices treating marginalized patients to facilitate improvements in health equity. And if you can go forward a couple more slides. And keep going. And this again, with respect to CMS, a recommendation here, the second bullet, to provide care management fees, non-visit based payments made to practices based on the size of the patient panel and the intensity of care management services required for the practice's specific population to support practice redesign. And the next slide. And here the third bullet with respect to CMS, to implement payment models that provide assistance to low-resource practices in poor and underserved areas to develop the infrastructure needed to provide care management. And the last two bullets, to allow the development and implementation of patient incentive programs and to increase funding for social services and establish better linkages between clinical care and community resources to address the social determinants of health and health equity. So I know that there was a lot on these slides. Most of the issues that I didn't touch on I think have been addressed, but these, the things that I just highlighted are some additional things that I think we might want to consider in terms of recommendations to improve care delivery and payment models for proactive team-based care. So that's all I wanted to say. I know we're running out of time, but if there are any brief comments, I'd welcome them.
Bill, I think this is Dean. I think it's hard to integrate the last set of slides. How do you suggest we can do justice to the content there? Or maybe I should defer this to Carol and Paul, since many of them relate to treatment and complications.
Yes. So I would be happy. Actually, I put these together some time ago, and I would be happy to whittle them down and pull out the things that I think might still deserve consideration and kick it to the treatment and complications subcommittee to look at.
Bill, this is Paul. I think the thing that the point that I'm wrestling with, and I think has been a recurring theme through this presentation, is that the recommendations at a broad level potentially have merit. Some of them I think are more meritorious than others, in my own personal judgment. But the fact that we're just maybe 3 weeks shy of voting on recommendations, and for many people they're hearing these either for the first time or considering them for the first time. They have not undergone the vetting process that other recommendations that were presented here today have gone through, where they've been discussed, revised, refined, and it's my sense that these are not ready yet, and the work to bring them to completion where people will be comfortable is quite daunting. And so I'm not sure how to best address this. I don't think that the Treatment and Complications Subcommittee is going to be able to take this on. We have provided some feedback. I don't think that we're going to be able to digest everything that you presented today in a way that we could come back with a recommendation to the rest of the commission that we've vetted and are going to propose these for vote.
Other thoughts on this?
I'm just wondering if, Paul, if there are, even the process of going through them as a subcommittee, or as the chairs of the co-chairs of the subcommittee, would illuminate those areas that are sort of no-brainers, yeah, we can get behind this, versus those that require significant vetting, versus those that would require a little bit of time, and sort of being able to make an informed group decision based on that assessment. I just don't want to throw the baby out with the bathwater, so to speak.
I understand, Dean. This is Paul again. And I appreciate that, nor do I. Dr. Greenlee and I have discussed this and think that there are probably three broad categories that could potentially be developed further. One I commented on, that relates to insulin pricing. I think there's broad consensus about that as a need to be addressed. The specifics of how it's addressed, some of the proposals that were brought forward are likely more detailed than most people in our subcommittee would be able to comment on. But as a broad recommendation, that certainly has a lot of merit. The second one relates to coverage of preventative services. We've discussed this, and that was actually mentioned early in one of the slides, such as DFMES, foot care, eye care, many of which are secondary prevention but are not routinely covered, pre-deductible. We think that there's room for that. That might be something that would need to be discussed, potentially for further refinement. And then the third area might be related to quality measures, not a topic that I have expertise in, but certainly I think that the proposed over-treatment measure is something that, again, might have some broad consensus. There might be others where there's the ability to coalesce around. So those three areas might be topics where there's some ability to harmonize. Dr. Greenlee, your comments?
I agree. I really think we do need to address the cost of insulin. I would prefer to focus on the out-of-pocket cost. I do love the idea of figuring out which secondary and maybe even tertiary preventive services and or treatments might warrant, like you said, no cost or lower cost. And then some of the quality metrics to help improve the care of people with diabetes. As I've already said, I'm not personally comfortable with some of the less defined and broader recommendations, but I am thinking we need to make a very bold statement that health care coverage and affordability is foundational to improving diabetes treatment and outcomes and prevention, but not the recommendations about employer health insurance, et cetera, et cetera. So I guess I'm saying I agree with Paul.
Okay, Dean, do you have any final comment?
Well, I think, I mean, I can certainly respect the process that Carol and Paul are speaking to. I would wonder whether the question of health insurance coverage should be more commission-wide decision rather than just putting it on their subcommittee, particularly given the discomfort that they might have around it. Because as you said, it is, Carol, it is foundational, and it's hard to imagine how we could make a recommendation about quality measures or insulin prices or diabetes self-management education if people just simply can't access those. The recommendation does kind of lose its teeth. So I'm just saying that I think not having a recommendation around health insurance would be a significant oversight, but I can understand why. I can understand the concerns around the level of detail and some of the scope that you might have.
I'm going to just give an example. The National Academy of Medicine has put out a draft report on how to improve primary care. They do address ideas on how to pay for primary care, but in their opening, they say that there needs to be health insurance and affordability, but that this isn't what we were asked to do, but we're making a statement that it needs, and I'm paraphrasing, but they didn't then recommend how to provide insurance and how to make insurance affordable. What they did is they addressed what they were asked to address, but they said that this is critical. And so just to share that with you, they then focused on what they were asked to focus on. But did call out that that there needs to be attention to affordability and available insurance or available coverage.
Right, but we were asked to comment in duty 2 on what gets in the way of clinicians being able to provide high-quality diabetes care. And certainly, in my experience and yours, what gets in the way is when people don't have health insurance. Like, that doesn't feel outside the scope.
Yeah, that would be duty 2 directly related to that. But I think we're going to need to close this now. And Jennifer, do we have any of the people who were to give public comment on the line?
Yes, Bill, we have Kate Curley from the American Medical Association. I'm going to go ahead and enable her microphone now, so she should be able to provide the comment.
Good. Dr. Curley, it's your time now. I'm sorry we're late getting to you. Please go ahead if you're still here.
Kate, your microphone has been enabled.
Hi, are you able to hear me?
Yes, we can.
All right, thank you. I'm Kate Curley. I'm a family physician and director of chronic disease prevention at the American Medical Association. Thank you for allowing us to provide comments on the National Clinical Care Commission's draft recommendations. AMA appreciates the updates that NCCC has made to its recommendations based on the comments we provided. My comments today largely highlight points from AMA's written comments, but I will also briefly address some of the updates discussed today. Overall, the AMA supports the comprehensive approach in the Commission's draft report. The AMA recommends that a health equity lens be applied broadly to diabetes and diabetes prevention policies and programs to better serve marginalized communities. The AMA supports a team-based care approach for both diabetes care and prevention, but recommends the Commission add, quote, physician-led, end quote, to the recommendation. It is important to have the team led by a physician to ensure appropriate diagnosis and treatment plans. The AMA would like to reiterate its support for Medicare coverage of screening hemoglobin A1C tests. This coverage is needed to align with clinical guidelines, and hemoglobin A1C is generally preferred by physicians and is the most pragmatic test for screening patients. We appreciate the Commission's updated recommendation to include all 3 measures from the AMA's prediabetes quality measure set. These measures were intended to be used together to incentivize comprehensive diabetes preventive care. The AMA believes the Commission's recommendation to fund research on the benefits of metformin for treating prediabetes is unnecessary as sufficient evidence already exists. The AMA recommends that the Commission present the currently available data to the FDA. The AMA urges the Commission to recommend that the CDC Division of Diabetes Translation establish a system to track the outcomes of all evidence-based interventions for preventing type 2 diabetes and not limit it to the lifestyle change program and its weight loss metrics. Also, the Commission should recommend that all commercial and public insurers should cover all of these evidence-based interventions. The AMA appreciates the updated recommendation for improving the Medicare DPP as we heard today. However, the AMA does not think that new model tests are needed and believes that CMS can fix several problems that threaten the existence of the MDPP through the Medicare Physician Fee Schedule process or via statute. The AMA welcomes the opportunity to discuss our comments with the Commission and identify other areas that would benefit from the inclusion of organized medicine. Thank you.
Thank you very much, Dr. Curley. Jennifer, did we have other folks wanting to make comments?
So none of the others joined today.
Okay, great. So I will turn it back over to Kara to see if you have any comments or concluding remarks.
I don't at this time, unless you would like me to do the meeting review close, or would you like to do it, Dr. Herman?
Bill, sorry, this is Dean. I had one thing I needed to raise. May I?
Yes, please go ahead.
And I'm wondering if Pat Schumacher is still on the call. So we had discussed last week the need to raise the issue that Duty 3 has to do with education and awareness, and unfortunately none of our subcommittees have addressed the issue of the National Diabetes Education Program, which was a joint effort of the CDC and the NIDDK to educate both the general public as well as those with and at risk of diabetes through what had been what I perceive to be a very successful program. I'm wondering if either Barbara or Pat could comment on NDEP and its demise, and whether we need to, since this was such a significant federal program and since Duty 3 is so clearly aligned with that program, whether we need to address the National Diabetes Education Initiative in some form. I think we've all sort of done it in small pieces in our subcommittees, but it may be for lack of a discussion of NDEP's history and impact that we've done it in a sort of divided way rather than as a full commission. Is that something we have time to talk about, Bill, or should we table it?
We are running about 35 minutes over.
Bill, I think you're muted.
Yeah, sorry. Barbara or Pat, did you have any comments about what happened to the National Diabetes Education Program and why it went away?
I mean, this is Barbara. I don't have personal knowledge. I certainly could speak to people here to get information for you, unless Pat has that personal knowledge. I defer to her.
Yeah, this is
Pat.
Yes, CDC has not been part of the National Diabetes Education Program for a few years now. That program we kind of deferred to NIH to lead. But again, I can get more background, more information on why that happened.
Yes, so Barbara and Pat, if you can, from your own agency's perspectives, see if you can find out what happened, because I think, as Dean indicated, this is a major focus for the National Clinical Care Commission, and before we make recommendations, we probably need to do a post-mortem on the National Diabetes Education Program.
Sure, I'm happy to do that.
I think not only sort of why it ended, but what gap it did fill, because I think when we polled the federal agencies, we were polling for activities that they were engaged in, not activities that they have stopped engaging in. So it's just a gap in our own assessment that would be important to fill.
Sure, no problem.
Great. Okay. So just to summarize, I think we've had very good and interactive presentations from each of the subcommittees and the work group. We now have 3 weeks before our June 22nd meeting to try to finalize and prioritize the recommendations. In doing that, I think we need to clearly think about how they relate to the duties of the National Clinical Care Commission. We're also will need to be setting up some cross-cutting meetings to try to reconcile, and we should probably highlight the recommendations that have emerged from single subcommittees that need to be discussed across the subcommittees and create an agenda for that. And as I indicated earlier, I'd like to have an open meeting of the work group with everyone who commented today to decide how to integrate and incorporate the recommendations related to access to health insurance and making medications affordable. Kara, did you want to add anything to that?
Yeah, hi. Can you hear me? Making sure my mic is still working.
Yep.
Great. I would like to say that, yes, it's been a great discussion. Thank you, committee members. Thank you, Dr. Herman. One concern that I still have after listening to all the recommendations is that I do not believe there is a recommendation that reviews or answers Duty 5. So if we could consider that over the next 3 weeks, I think that's a very important priority. And just once again, prioritizing staying within the scope of the charter. I concur with the conversation that just happened with Carol, Paul, Dean, and Bill. I think it was a robust conversation, and I look forward to the working group meeting coming up. And thank you, everyone, for your hard work. And we look forward to day 2 in about 3 weeks. So thank you.
Great. Thanks, everyone. And thanks for staying on. Sorry to have run late today, and look forward to talking again soon.